as well. Okay, so I'm just going to move on now to our next speaker, Dr. Nicola Maran. Nicola is one of my colleagues in NHS Lothian, where she works as a consultant anaesthetist, but she's also the Associate Medical Director for Patient Safety within NHS Lothian and has oversight for all the national safety programmes. I've worked with her really since arriving in Edinburgh very closely around deteriorating patient, and Nikki currently chairs the deteriorating patient group within NHS Lothian. She also has a strong background in clinical simulation and set up and directed for a time the Scottish Clinical Simulation Centre. She has an interest in human factors, and I'm really interested in whether that interest has been useful as in this project, which is electronic OBS within NHS Lothian, a system that is just launching now. And Nikki has been very involved in many of the aspects of this project, particularly around testing. And it'll be interesting to hear what she has to say today. So over to you, Nikki. Thank you.
Thank you very much, Gregor, and thank you for the invitation to present some of our experience to date in Lothian with doing things a slightly different way and with developing. So rather than looking at one of the off-the-shelf options, we have actually worked within NHS Lothian to develop an eObs system that integrates into our existing electronic patient record, which is the track system. So can we move on to our first slide? So why eObs? So Gavin has already talked about many of the same things that we have found in Lothian. We have for a number of years had a very kind of comprehensive and reliable system of identifying and then reviewing our 2222 calls on cardiac arrests and medical emergencies. And what the learning from that has indicated that we have had some issues with our reliability around accuracy of news scoring, in particular, a lack of reliability around frequency of observations and missed observations in patients who then go on to deteriorate. And it is often difficult to see good documentation around times of escalation. And we know that our documentation around special instructions for tolerances around chronic physiological changes in our patients are, again, not very good. And again, as Gavin has already alluded to, our SAE reviews and 2222 reviews often have indicated that we have failed to have a kind of shared oversight of the sickest patients in our hospital, in our department, or at a ward level, and to have a shared understanding of that. Next slide, please. We were keen, so there are a number of off-the-shelf options around electronic patient track and trigger systems, but we were very keen to explore whether it was possible to integrate the electronic observation system that we were going to use within our own electronic patient records, such that it was accessible within the EPR for every patient, which would actually make a lot of the kind of hardware and access options easier for staff. And next slide, please. We wanted to develop something, again, Gavin spoke about this, about really trying to make this feel like the current process and reflect the current processes, but happen within the electronic system, which has a number of the benefits that Gavin has covered and that I will also simply repeat that we've found within Lothian. So the processes around news functionality, we're collecting our data in the same way. We are entering the data into a tab within the track system, which allows us, which adds up the scores as we go. And we also have an ability to reset, to set our special instructions, and to change the oxygen saturation scale within tabs, again within the track system. So it's all very easy and basically works the same way in terms of our data gathering and entry as our current systems. And again, next slide. And we have managed to create then a chart that really looks exactly the same as the paper chart currently that is at the end of the bed. So this chart completely reflects the News 2 chart from endorsed by the Royal College of Physicians, along with the extra fields that we had created within NHS Lothian for making for entering data around urine output, blood glucose levels, circulation sensation, motor movement, and surgical drains. So what appears in our electronic patient record completely reflects what is currently in the chart at the end of the bed for familiarity for all staff. Next slide. And so as Gavin has already alluded to, the benefits of an electronic eOb system are that addition. So when we enter all of the physiological data into the system, we may not enter it correctly, but the total score is always added up correctly. And then there are prompts then to as to whether or not it's appropriate to escalate the patient with access to any special instructions that have been set within the same frame in the track system. And then when you enter the data into the chart, you're presented with exactly the prompts that are available on the current paper chart around the actions that you should be taking to address any problems with the patient's physiology, such as applying oxygen, considering sepsis, and discussing with the charge nurse on the ward or escalating as appropriate. So we've got the prompts built in exactly the way that they are within the current news charts. Next slide, please. So what this system does not do is to automatically trigger. So we currently don't have the capacity to link this to to our telecom system, although this is a capability that we may be able to address in future. But what it does do is to make it very easy to use a tab to describe where the escalation call has been sent. So what grade of staff the patient has been escalated to, and what the clinical concern, whether it was news score, clinical concern, high lactate, or suspected sepsis, or any other reason for escalation, can be very easily documented into this tab. And then that enters directly into the clinical patient record. So it's very easy for staff to document that escalation. Next slide, please. So I'm just going to take control here of the slides, hoping this still works for people. And now I've got a terrible view. Sorry.
Thanks, Nikki. We can see your pointer there.
You can. The trouble is, can somebody remind me how I can make this slide bigger, because I can't see what I'm pointing at.
Okay, if you go to more, and then you go to some content, that'll give.
Oh yes, thank you. Thank you, Gavin. Okay, so so here we can see what the floor plan on our track patient record looks like. So this is a kind of what the floor plan for a ward would look like. And on our floor plan, we will have here the news score of the patient, whether or not the whether that set of OBS is increased or decreased from the previous set of OBS. There is a timer here that lights up when within 10 minutes of the next OBS being due, or that demonstrates that the observations are overdue for the time. There is an indication here of escalation. So this red icon, the red circle with the up arrow, means that the patient has been escalated for clinical response. When the clinical responder is actioning that call and alerts that through the escalation tab, this turns grey. So this is an indication that the patient's been being dealt with by somebody, but not yet better. And when that when the patient is better, then that icon will be switched off. And if a patient is re-escalated, so there isn't a response within the allocated time, or there is a further deterioration and further escalation call, then that escalation icon has a black line around it. So gives us, from a floor plan perspective, an ability to see what is happening. And you can see in some of these, we've also got the TEP, the treatment escalation plan icon, is also available on the floor plan. So at ward level, that allows staff to have a really clear oversight of what is happening with all the patients on the ward. And then we have, as Gavin has talked about, an overview board, which allows us to see to arrange this by news score. So to identify the most unwell patients in any given area. And we can set this for a site, for a speciality. So we could set this for acute and general medicine, or for MOE, or for general surgery. We could set it by consultant, or it could be set by a single ward. So you can arrange and see who the sickest patients are in a number of different ways. And again, when you see this oversight board, it gives you an overview of the change in news score, the time and date of the last set of observations, whether there are special instructions in place, and the escalation status and the treatment escalation plan, if that is available. So that gives us that kind of consolidated view of all the information we might need to have to see the overall status of patients at, as I say, ward, consultant, speciality, or site level. And we can search for individual patients or individual specialties or consultants within this. And from this oversight board, just clicking on the patient's name will take you back to their EPR, and clicking on the news score will take us straight to that news chart within the electronic patient record. So it gives very easy access and overview, the importance of that communication that Gavin was talking about for use at at the level of the ward round, at handovers and huddles, and at site level. So if I can now just kind of, so if I just a little bit about how we went about this. So the development of this project was absolutely led by Gillian Macaulay, who is our acute nurse director, and was part of a whole piece of work that she led around the model ward, getting all of the all of the good care around wards onto our electronic patient record. It was a multi-professional team, and we absolutely could not have done this without our eHealth colleagues, who have been amazing in helping us with the development, with nursing medical input across specialities and across the sites. Our quality improvement support team and our care assurance standard and quality improvement teams have all been involved in coming together to develop and test this. We've had regular weekly, fortnightly meetings to review findings of our testing at local and wider level. I'll come on to talking about that in a moment, and to have that kind of rapid learning and adapting to the challenges that we've identified. So rapid decision making, and we have also developed our measurement plan for use in both our testing and our implementation. As Gavin has already highlighted, the importance of that feedback around we've made these changes. Is this working? Is it doing, some true PDSAs around, is this doing what we predicted, and if not, what further changes do we need to make? And we've reported that and got approval for the various steps through our acute clinical management group. Next slide, please. So there have been numerous glitches along the way, and with obviously we have had to do extensive testing of this system. Mostly we have done that in the development environment of TRAC. We have some challenges around the interfaces. So at the moment, we are still using computers on wheels to enter our data, and that presents a kind of challenge in terms of our interface. I'll come on to talking about that again in just a moment. And we have identified through our testing some issues with our current SOPs. And where we did, one of the things that we saw when we tested the system in the live environment was very quickly people saw what was available and just thought, this is brilliant, we want to use it. So we had some early adopters who we've had to keep an oversight of, and control of, which has been quite interesting. But it, in a way, just illustrates how keen the staff are to be involved in this. Next slide, please. So, as I say, we have tested this in the development environment. We've tested, we have tried out, simulated low fidelity, mid fidelity using mannequins. We've tested on desktop. We have used simulation over and over again to test our hypotheses around how the system would work under different conditions, both with well patients and also with simulated sick patients, to test both data entry, actions and response. And we've done that with multiple staff of different grades, different professions in different specialities, sites and contexts. And we have in the same way tested our training materials and our contingency plans for what happens if patients are transferred between areas which have and don't have the electronic record, and what happens if our electronic patient record were to go down. So we have used simulation in every at every level to test what we have developed. Next slide, please. So we launched our eObs system in one of our community hospitals last week in one ward. We have tested it on one ward during the week, again with multiple iterative feedback involving staff of all grades and professions, and yesterday have rolled that out to the other 4 wards on that site. A reason for choosing a community site is mainly that around the hardware at the moment, and the community sites do less frequent observations, so and we've got enough hardware there for the staff to have enough access to the hardware to be able to enter data onto the laptops and computers that are available there. Next slide, please. Our implementation plan involves scaling up through our other community sites and then probably to our mental health hospital before coming into acute. And before we get into acute, we absolutely have to have a better hardware interface option, so that with handheld devices. And we're also looking at the ability to directly interface our Hewlett-Packard Welsh Allen monitoring devices into the track system. We have also been reviewing our current escalation SOPs through our simulation testing. It was quite clear that we have our SOP is not well followed, and so we're having a look at our SOPs and testing some changes to the SOPs, and everything just involves regular review, revision and testing, and just being flexible. Next slide, please. So we couldn't have done this. It would never have started without the instigation of Gillian Macaulay, and she has been absolutely amazing in chairing the overview group. As I say, we couldn't have done any of this without our eHealth team, who have been patient and flexible in the extreme. Carolyn Swift and the quality improvement team, Lorna Turner, Laura Thompson and the LACAS team, and Kenzie Smith, one of the charge nurses in our acute medical ward, and so many other staff across the system who have given their time to help us to develop a system that works for them and that works for patients. Thank you very much.
Thank you very much, Nikki. Wow, I mean, that's a huge project. And again, I've got lots of things I would like to ask you, and just really the granularity of those slides there that we can see and kind of envisage the system and how it's going to roll out. So it's really very interesting.